some slides which I had hidden, unmasking. Yeah, so good morning everybody again for the third time this morning, and I will be speaking on small pupil. Like I just said, am I audible? Yeah. So if you have not heard this talk or seen this talk in the last 2 days, you've not been attending the conference, because this is the third time I'm speaking on this in different halls. Sometimes in the same hall as back to back in this particular case.
We can't have enough of you.
Oh, thank you so much. I love it. Who doesn't like it? Who does?
You know the pupil, we are the pupils.
That's a good one. That's a new one. Though it doesn't, that word doesn't suit you very much. Anyway, chalo. So it's all about anticipation. I'll try to keep it interactive, and you can, because we have 12 minutes, so you're free to ask questions. I'll be happy to answer. I do have a financial interest in the BHEX, so no way will that come in the way of academics. So the problem with small pupil is when the pupil size is reduced to half, the surgeon's viewing area is reduced to a quarter. And if the surgeon can't see the cataract, it's a disaster because he can't operate safely. And again, I always say that you need to ask yourself every time it's a call that you need to take, judgment call. If you were the patient, we've all burnt our fingers. We've taken that call, not taken that call in the right time, we've delayed it, we messed it up, we've damaged the iris, we've had a bad situation, complications. So if you were the patient, what would you ask for? A skilled surgeon with no device, or the surgeon use the device anyway? So it's a 4 millimeter pupil, you're on the table, your eyes on the, under the knife, what would you want? So put yourself in that position and then probably think about the patient, it helps. So a lot of us say, nahi, this is 6 millimeters pupil, isme to IFIS nahi hoga. I'm definite. Well, this is the paper published in 2011. 7 millimeters pupil or less, without alpha blockers, the risk of IFIS exists. And we've all seen that. We've all seen people suddenly comes down on you, out of the blue, you don't know what's happening. And that is the list. The risk of IFIS and the causative agents, the risk is actually endless. This is an abridged list. That's the list of drugs, and hypertension, chronic heart failure, diabetes. These are all risks for IFIS, and every other patient of ours has this. So it is unpredictable. Let's come to terms with that. And fortunately now surgeons have reduced that threshold. We have become result oriented, so we need to know that IFIS is unpredictable, and there are patient expectations are absolutely exacting, and they, like they said, they are talking of the bags under their eye, and they are blaming you for that. They not come to you for vision. That is now become second priority. And so unforgiving nature of premium lenses, toric lenses, multifocal eyes, you don't want people coming down on you. You are already under stress. So use a disciplined approach, have your devices in stock, treat every eye as a potential IFIS candidate. Use viscoelastic judiciously. Dr. Himanshu shows that. I would always strongly recommend that you distinguish between elastic and a non-elastic pupil. That's something which I have learned and I've tried to teach people, and I hope people are understanding these days that these two are very different animals. So how big we want the pupil to be, we always want the pupil to be very big, and that's a psychological factor. Otherwise, we are happy to take up a pupil which is 5.5 millimeters and does not come down. We think, okay, we can get past this. But when we put an iris hooks or we want a pupil expander, we want it bigger. It's just in our mind. Hard cataract, it has to be bigger pupil. So choice of pupil device is totally individual. I'm not advocating for or against either, but OVD or iris hooks or pupil expanders, I think it's the elasticity of the pupil and how you wish to tear the rigid pupil is what matters. IFIS, Dr. Rohit will be talking about it, but I have a take on that. So I believe that injecting viscoelastic and inflating the anterior chamber is really counterproductive. You are pushing the iris against the anterior lens capsule, you're plastering it, so you're not leaving space for the device, whether it's iris hooks or pupil expander. So it's best to keep the anterior chamber shallow and inject a little bit of viscoelastic under the pupil margin. That way you lift off that pupil margin and you create space for your pupil device. So keep the anterior chamber a little shallow. Overfilling is going to be counterproductive, and use viscoelastic under the pupil margin. So this is what actually I went back, and when we all have seen this. See, we've seen IFIS before 2005. Once Chang and Campbell told us about it, we know, okay, this is called IFIS. So then they realized, we realized, fine. But what came out of this paper, and probably was kind of buried somewhere, was unlike the non-elastic myotic pupil, the IFIS pupil immediately snaps back to its original size falling attempts to stretch it. This is one sentence over there in that paper, and I think most of us fail to look into this so closely. While I was working on the BX and trying various prototypes, various dimensions, various materials, the flexibility, the resilience of that, I had to come to a point where it was a trade-off between the thickness of the material, the flexibility of the material. So then I went back and realized that when I used a softer material, in some cases I was just stuck because the pupil would not budge. It's a rigid pupil. That's when I realized, well, some places, in one eye I got away and the next eye I didn't. So there was a problem, there was a difference in the nature of the pupil, and that's when I went back and did more literature search and realized that yes, we need to differentiate. So if it's a rigid pupil, you need to work. So small pupils are two types, the elastic pupil or the non-elastic rigid pupil. We have to be very clear about that. The elastic pupil is like a rubber band, it's going to stretch. Any device works. It's open to stretching. The non-elastic is like a string. You can't stretch it. The circumference is fixed. So you have to tear it. You tear it. The pupil margin is fibrous. So you need either a bulky pupil expander like the Malugan or the I-ring, which is strong, tagda, okay, and can do the job for you. Or you use Kugler hooks to get a controlled stretch by manual, and then you use a delicate device like the BX. The choice is yours. We could check the elasticity of the pupil. It's a very, very simple test. We do it, actually, we don't see it. As soon as you've done your paracentesis, just inject BSS into the anterior chamber. Inflate the anterior chamber. If it momentarily expands, it is an elastic pupil. If it doesn't expand or doesn't budge, you know it's a rigid pupil. Irrespective of the posterior synechia. If the posterior synechia, that's a different thing, but you can release the posterior synechia and then do that. So if it expands, it's an elastic pupil. You don't have to worry. Otherwise, you just stretch it. Don't have to go limbus to limbus. Just enough, about 4.55 millimeters. You make it favorable for using a device. Even if you're using iris hooks, I would say you do a bimanual stretch, get a control. You have a much better cosmetically looking pupil the next day. And do not stretch the pupil beyond 5.5, even if you're using iris hooks. There's no point. So mechanical dilatation of the pupil, IFIS is useless. Do not stretch. I mean, when I say so, mechanical, it's stretching. And for rigid pupils, yes, it has a place. And you could use whatever you are fond of, iris hooks or pupil expansion devices, the Milligan ring or the BHEX. So a few things about the iris hooks. So I prefer, I mean, this is a very old video. I have stopped doing hooks for a very long time. There are surgeons over here who do a much better job than me. But I prefer to, small things which I learned that time was make a small conjunctival mark over there, because if you're using clear corneal incision, you won't be able to find that paracentesis of yours. And then you hook it, make sure that the stopper is retracted far behind, because it becomes very embarrassing. You put that hook inside and then you say the stopper needs to go back. That's a lot more manipulation. Do not retract fully. This is an over-retracted pupil. That's the tendency we had in those days. Stretch it as big as you can. And whenever you're inserting instruments in the eye, remember that the pupil margin is at an elevated anterior plane, it's at the limbal plane. And often the pupil margin is antiflex. So every device that goes in, side port instrument that goes in, you need to take care that you go around that pupil margin. So taking out is no big deal. Actually, people use various maneuvers. Just retract that stopper a little bit, advance that hook and just pull it, yank it out. That's a proper polypropylene or nylon, and it will just stretch momentarily. You don't have to twist it, turn it, and all that heroics. You don't have to do all that. There is a downside to iris hooks. That's the reason I think people are moving to pupil expanders. Those who don't find a downside, it's perfectly all right. Please continue with your iris hooks. It's all very subjective. So there is definitely a theoretical risk of infection with multiple incisions. Iris sphincter tears is a reality. We tend to over-retract. We definitely tend to over-retract. And if you look at it, all our work is within the capsular excess margin. We are not going to work outside that capsular excess margin, that 5 millimeters capsular excess. So why do you want those corner spaces? That's absolute waste. Your anterior chamber is becoming a little shallow. So if you have already shallow AC to start with, you again raise the iris to the limbal plane. So you have a shallower AC, you're cramped, the chances of iris trauma and endothelial damage again are increased, and the time is increased. Now you may be very competent and everything. It has been proven in a publication that iris hooks take more time than a pupil expander, and the time taken for consultants was 14 minutes more, and for trainees was 24 minutes. So that's a lot of more time which could have been saved. And of course, you could have permanently dilated pupil with terrible glare, and an unforgiving patient is not going to be very happy about it. And cosmetically, nobody wants to see this first day post-op, or maybe not first day. Actually, this doesn't show up on first day post-op. This shows up on 3 months post-op, and that time it looks very ugly. So one of the devices that is available is BHEX. It's a hexagonal device which notches and flanges, and you have tabs for holding. That's a 7-minute, I think, yeah. So it's a very thin device, as thin as a human hair. So you can, once you use it, you'll realize it's super thin. It's a very simple design, user-friendly, no rocket science, affordable. In fact, the design is deceptively simple. I would strongly recommend that you see a few videos before you first use it, because there are surgeons, especially, I've had key opinion leaders who are actually great surgeons who came back and told me later, I got fooled by the design and went in for my first surgery thinking, that's mere baएं हाथ का खेल hai. So, and then when they didn't find it very comfortable, they went back and saw a few videos. Then they saw, yes, it's really baएं हाथ का खेल if you have seen a video before. Okay, so it's very simple, but you need to see videos in advance. So the advantage is it's in a housing, it's preloaded, it's available sterile at the incision. You just need to hold it with that forceps, BHEX forceps, and carry it into the eye and tuck the flanges. A very simple forceps using is no big deal for us. And the housing is transparent, so it allows you visibility through the entire passage, entire travel of the device. You see the device, it's under your control. You're holding the flanges, you're not leaving the flanges at any point in time. When you're using a device with an injector, you have no clue what's happening inside. It could be twisting, turning, you don't know how it's going to come out. So, or get in for that matter. So if we compare the BHEX with the Malugin ring, that's the standard of care apparently. So you have scrolls over there, you have notches and flanges over here, and it is 1/10 the thickness of the Malugin ring at the corners. And if you have a shallow anterior chamber, actually your chamber is shallower. In the center, you're practically at half depth. So you must understand the periphery. Actually, it's at the periphery, you're half depth. Mid-periphery of the anterior chamber, you're half depth of the central anterior chamber. So if your ring is going to be in the anterior chamber at one point in time, you will be knocking the endothelium. So be mindful of that. In a shallow anterior chamber, you need a very thin device. And here, the entire device is in a single plane. So, and the iris can be bent harmlessly. We know that. How big do you want the pupil to be? Now, when we all started surgery, hard cataract, we wanted big and huge. It's hard cataract. It's a big nucleus. It's going to come. I think you're going to fragment the nucleus. You're going to take it out piecemeal. So why do you want a big pupil? You're not doing an SICS or something. Even in SICS now, people are fragmenting it and then taking it out. So why do you need a big pupil? So a 5.5 pupil is adequate for any grade of cataract. We need to take up, when we do routine surgery, if we take up a 5.5, I might get away with this, so I won't use a device today. But when you put a device, you want it value for money, no? You realize the value for money. पैसे डाले हैं भाई, हाँ, कितना देती है, जितना देती है वसूल करो, ठीक है? So, this is a hard cataract. Deepak Megur, of course, he's a skilled surgeon, he's a great educator, great friend. Less than 4 millimeter people, a little bit of stretch, and 3 flanges tucked, alternate flanges tucked. This is a 5.5 pupil. That's all it is. It's a very hard cataract. Just chop it into as many small fragments as you want. It's going to come out. Your capsular axis is not 7 millimeters, isn't it? When you're doing a phaco. So why do you want the pupil to be at 7 millimeters? So that's a simple logic. I think IFS, I think I'll leave that to Dr. Rohit. He's going to speak about that, but just I'll go to one slide. Sorry, we'll skip this. So one slide over here, which I feel strongly about, is there are 2 components, meiosis and iris prolapse. For meiosis, iris hooks, pupil expanders, perfectly all right. They provide constant pupil size, good visibility, safe phaco. That's all you want for the meiosis part. Iris prolapse, nothing works. Nothing works. That day, that iris, your luck. Severe iris is going to prolapse out of every port. Every port. Okay. So, if you got away with IFS with a particular device, no credit to that device. Your naseeb that day. Okay, as simple as that. Okay. Let's get clear about. So, what you want is a good visibility. Forget about the iris prolapse. That will keep prolapsing. you might have a torn and tattered iris, but what you want to do is get away with that cataract surgery. So if you have good visibility, you're safe. So any device will do that. So thinner the device, the better it is. I believe something which requires small incisions, has a low vertical profile, can exit through the side port. So the iris hooks and the BX would, I think, fit the bill over there. They check all the boxes. Look at this. This is a 1 millimeter side port or 9.9 side port, and I'm using the BHEX. I'm taking it out through a side port. No device could, no pupil expander in the history of ophthalmology has been able to do that. So, and in tight situations like IFIS, shallow AC, it works very well. Intraop meiosis. Now, this is another situation I'm very keen about. So, when you're using a Mulligan ring or an eye ring, the iris pupil margin engaging parts on the side. So, it's like this. So, the pupil margin is over here. You got a top view. You can't see what's happening over here. So, with the BX, it's like this. The notches are facing you, and as you hold that flange and tuck it under the pupil margin, carry it to the periphery, you have instant confirmation that you've not engaged the capsulorhexis margin. If you have engaged, you come back a little and again disengage. You have control over that flange throughout. When you're using a device with an injector, you have no control over that, and you don't know what's happening while the pupil margin or the capsulorhexis margin is getting engaged. So that is a huge threat. That's a huge threat. Shallow anterior chamber, 75 microns, that's the thickness of the BX. And you just, and this was a complicated shallow anterior chamber, and like that's Deepak's preferred side port. Most of us prefer the side port because in a shallow anterior chamber you won't like to go to the main incision, that will shallow the anterior chamber. CTR being used, no problem. So as long as you have a constant pupil size, I think most of us are very comfortable doing surgery. Taking out always is very easy. This is a video which is available. It's a matter of big honor for me. It's available on the American Academy website. It's a very difficult surgery, a glaucoma tube shunt in place. No device can you manipulate like that around that tube shunt. Single incision, all the 3 flanges engaged. Look at what he's doing. That is the 3rd flange, and it's going around that tube shunt to engage the pupil margin. No device can do that because you have control at the site of action by the forceps jaws. You do not have that kind of control with any other device. We have become slaves of technology in some ways, which is actually, we don't look at our interests. When you're using an injector, everybody, I've faced this for a very long time. Fortunately, now people have learned. So many people ask me, don't we have an injector for the BX? Why? Because the Mulligan has it. Right? Do you do everything that your neighboring surgeon does? So think for yourself. The injector tube over here was because the Mulligan ring is a biplanar device. It is going to snag the incision while going in and while coming out. It's a biplanar device cannot go in through a slit incision. It is going to get stuck. So the injector was made to circumvent that problem. And when you use an injector, you are losing precious incision space. We are working on small incisions. So the injector tube wall has a thickness. You're losing space over there. Why do you do that? And the forceps is so much easier. Then there was an argument that, well, you were using, see, it's sterile. You're delivering the device sterile. There's no conjunctival touch. Oh, is that so? So your phaco probe, sleeve, what's happening to that? There is no conjunctival touch when you're going in. So we have become slaves of the West sometimes, and we don't think ourselves. So better start applying your mind to what you want. This is a femtophaco, Ajay Paul, doing it. 4.1 pupil, and the pupil comes down, and go ahead with the femto. And now once the pupil has come down, now you have femto also is known to cause a little bit of meiosis, about 1 to 1.5. That is there in the literature. Most surgeons believe it doesn't now. But then after a femtophaco, I think your capsulorhexis is a little delicate, so you would prefer to use a device which you have more control over. That's your choice again. So it's pretty easy after that. So that's the lens going in. Actually, my good friends have done more surgery and more variety of surgery than I have. I don't have access to a femtophaco, so they do it. So intraop meiosis, yes, it's either the iris hooks or the BX ring. Subluxated cataracts, I would always use iris-hooks. There is no doubt about that. I will always use, because I can do asymmetric pupil expansion in the particular quadrant on the clock hours that I want. I'd encourage you to look at this particular PDF, which is available on our website. It's got useful video links throughout. It's, I think, 8 pages, and it tells you all about the BX, all that I've spoken, and more. And this is about phacoemulsification in small pupils, available on eophtha.com. I'll be happy to answer any questions. Thank you very much for this.